Today, we're diving into a fascinating medical paradox. It's a condition where one of our most important organs is actually working too well, and in doing so, becomes a serious threat. Welcome to the very strange world of augmented renal clearance.
I mean, really think about that for a second. When you think of intensive care, kidney failure is one of the big fears. But what if the exact opposite was the problem? What if a patient's kidneys were so incredibly efficient that they actually put their recovery in danger? It sounds completely backward, but you know what? It happens all the time. So, what is this hidden threat? Let's break it down. To really get it, we need to define what's happening and figure out why it even starts in the first place.
Okay, so the official name for this is augmented renal clearance, or just ARC for short. It's measured by something called creatinine clearance, which is basically a speed test for your kidneys. Now, a normal range is somewhere between 90 and 120, but with ARC, we're talking about a clearance rate over 130. These kidneys are in total hyperdrive. So, what kicks this into gear? Well, the main theory is that it's actually an unintended side effect of some life-saving treatments. In the ICU, patients get a lot of IV fluids and often need drugs called vasopressors to keep their blood pressure up. All of that can send a massive amount of blood flow to the kidneys, pushing them into this super fast state. And you might be thinking, this is some rare, obscure thing, right? Well, not at all. Studies show that anywhere from 20 to a jaw-dropping 65% of critically ill patients can experience ARC. That means in just about any ICU, this hidden problem is incredibly common. So why is this so dangerous? Well, because kidneys working that fast don't just clear out waste. They flush out crucial medications, especially antibiotics, before they can do their job. And the result? One study found a treatment failure rate of 27.3%. That's more than double the rate for patients with normal kidney function. This is one case where faster is definitely not better. So this brings us to a really important question. Who is most likely to have this? If doctors can spot the typical patient profile, they can be on the lookout from the very beginning. And this is where it gets really weird, because the profile is the exact opposite of what you might expect. We're not talking about the oldest, sickest patients. The risk is actually highest in younger people, under 50, who are often male and very often trauma patients. They also tend to have lower SOFA scores. That's a way to measure organ failure, which means, on paper, they're actually less sick. It's a true paradox. As one source puts it, these are often the healthiest of the critically ill. Their bodies just have more reserves, with fewer underlying problems that might slow the kidneys down. So their system has the power to ramp up into this dangerous, super functional state.
All right, so if the healthiest looking patients are the most vulnerable, how do clinicians actually spot this condition? Well, it comes down to a couple of key detection tools. For a quick check right at the bedside, there are scoring systems like the ARC and ARTC scores. They use those risk factors we just talked about, age, trauma, gender, to quickly build a risk profile. A high score acts as an immediate red flag, telling the team that standard drug doses probably aren't going to cut it. But those scores are just an estimate. To be absolutely sure, the gold standard isn't an equation, it's a direct measurement. It involves collecting urine over a set period, usually at least 8 hours, to see exactly how much waste the kidneys are clearing. This gives a true picture of what's happening, no guesswork involved. So, once ARC is confirmed, the real challenge begins. The medical team has to solve this complicated dosing puzzle, and that means completely rethinking how they give some very critical drugs. Now, to understand the solution, you need a quick pharmacology 101. Antibiotics basically work in two main ways. Some are time-dependent, like beta-lactams. For them to work, the drug level needs to stay above a certain line for as long as possible. Others are concentration-dependent, like vancomycin. They need to hit a really high peak to be effective. And guess what? ARC messes with both of these strategies. So for those time-dependent drugs, the game plan has 3 parts. First, you just maximize the dose. Go with the highest amount that's approved. Second, you change how you give it. Instead of a quick injection, you use a prolonged or even a continuous IV drip over several hours. This keeps that drug level nice and stable. And finally, whenever you can, you actually test the blood to make sure the level is right where it needs to be.
Now, the common antibiotic vancomycin, that's a whole other beast. ARC clears it so fast, it's almost impossible to keep an effective amount in the body. In fact, one study found that almost 69% of patients with ARC had drug levels that were too low to fight an infection. That is a massive potential for failure. And the problem starts from the very first dose. In a study focused on trauma patients, a super high-risk group, only 16%, 16, actually hit their target drug level. It just goes to show the standard playbook for this antibiotic is useless for these patients. So to fix this, the guidelines have totally changed. The old way of monitoring was called trough monitoring. It was kind of like checking your car's gas tank only when the empty light was on. The new strategy, called AUC-based dosing, is like calculating the total fuel you've used over an entire day. It gives a much, much better picture of total drug exposure, and it usually starts with a bigger loading dose to get things going.
And what's really amazing is that recognizing ARC is doing more than just changing a few prescriptions. It's fundamentally helping to create a whole new standard of care in the ICU.
You can see this shift happening all over the place. Clinicians are now adjusting doses for other kinds of drugs, like certain antifungals. And what's really telling is that brand new antibiotics are now coming out with specific dosing instructions for ARC already included in the manual. The entire field is adapting in real time. So it all boils down to this new mantra of vigilance. You have to regularly check kidney function, you have to be ready to change up the drug doses, and you have to monitor the drug levels whenever possible. It's really a huge step toward truly personalized medicine right there in the ICU. And that leaves us with one final, pretty big thought. ARC has taught us that even a healthy, supercharged organ can become a liability in the wrong situation. It really makes you wonder, as our medicine gets better and better at supporting critically ill patients, what other normal bodily functions are we going to discover that we need to rethink to give patients the absolute best care?